Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.
Thank you for downloading and listening to This Pathological Life. If you're interested in continuing the story, we have a second series called This Medical Life. Please download it and subscribe now.
Dr. Travis Brown, why do we need a podcast called This Pathological Life?
Every disease has its own story to tell, so we're going to tell them.
Wait! Stop! Don't eat that food!
Who are you? What are you doing in our house?
I'm from the future. I'm here to warn you, don't eat that food.
Why not?
The eggs, they're full of cholesterol.
What?
Cholesterol, it clogs up your arteries. Eating even just one egg can dramatically increase your chance of heart attack. Don't eat eggs.
Oh my God, thank you.
You're welcome. Godspeed.
Just when I thought you'd thrown all the words at me that I'd need to learn for this podcast, atherosclerosis is a new one on me. A pigeon pair with cholesterol, they're the topics that we're looking at today. Dr. Travis Brown, I know our listeners know this, but just fill us in. What do you mean by that?
So atherosclerosis, ischemic heart disease, coronary artery disease. So this is the leading cause of death in Australia. So 10 to 15% of all deaths are related to atherosclerosis, coronary artery disease, ischemic heart disease. And so, look, we'll take it a little bit different. As opposed to doing a story first about the history, we'll take you through the pathogenesis of this disease, because it's important to put it into context. And so if we look at atherosclerosis, it's pretty much fatty plaques or fatty streaks that become fatty plaques and cause occlusion in vessels. Now, if you occlude a vessel, anything behind it will lose oxygen, will lose nutrients, and ultimately, if it's not fixed, will cause tissue death.
Right.
And so that's the basis behind coronary artery disease and heart disease, is a vessel gets either occluded and then causes a heart attack, if you want to go down that line, because you occlude a vessel and it loses all its nutrients and the tissue dies. And so if we actually look at the word, it is Greek. It means for either gruel or hardening. And this is, going back to, pathology 101, you have a normal vessel, we get a fatty streak that becomes a fibrofatty plaque. And when you think about that disease process, we actually know how it comes about these days. To be honest, even I've read some articles saying that, a fatty streak can even start to develop in, children the age of 2 years of age. So this is a, early developing pathological process. And you step through the process of how this disease develops. You'll have a vessel, and the lining inside the vessel is endothelium. And so what we get is this chronic endothelial injury to an area. Now, we know where these happen. They tend to happen in turbulent areas. So if you have the coronary vessels, you have the heart, the coronary vessels around there, at the branches is where it tends to be a little bit more turbulent, and that tends to be where you get this just chronic endothelial injury. So for some reason, the endothelium that lines the blood vessel gets injured. This can be things like, smoking or whatever, for whatever purpose, but it just becomes injured. And what happens with injury, with any part of our body, is you get dysfunction of the tissue, and then you get monocytes. So they're blood cells, inflammatory cells, that adhere to this injury area. And then they migrate in that area, and that causes them, when they become monocytes, going from blood into tissue, become macrophages. Mm-hmm. And so what you have is an area of inflammation, and then you start to get migration of smooth muscle. And so we then also get lipid engulfment. And then because the macrophages inflammation, they start taking up lipid that are there and become foamy cells. And so we then start to get smooth muscle proliferating, and you start to get endothelium lining that fatty streak or that inflammation area, and you get smaller vessels. And so that's the whole pathological process. And then eventually what will happen is, three things. You can either get critical stenosis, so the vessel becomes the lumen becomes so small that tissue further down starts to lose nutrients, and it becomes stenosed, and it becomes ischemic. So it takes up until about 70% of your coronary arteries become stenosed for you to get symptoms. So this is what we talk about angina. So someone does exertional angina, you've got a stenosis. Well, the tissue, the muscle as it's pumping, is requiring more nutrients, more oxygen, but it's not getting it because of the stenosis. So you'll get pain in the heart, angina. The other things you can get is an aneurysm and rupture, but you can also get the plaques that become injured and thrombose and then occludes, and then you have an acute myocardial infarction or an event. And so what we know, so there's a few things. If the fatty plaque is there for a while, it can calcify. And so it can take years to calcify, but this is why we do calcium scores on there, because if they do, calcium elevation, there's theoretically a lot more of the calcium there, therefore a lot more atheromas there.
Is that here's my plebeian question: is that hardening of the arteries? Is that what
it is? It is, and so we've even done autopsies on patients, and when you have to examine the coronary arteries, when it's all calcified, it actually blunts the knife as you're cutting through it. So it's actually real hardening of the vessels, and so. This is often thought as a modern disease. And, when we talk about, high saturated fats and processed meats and sugar, we think, this didn't occur previously, but that's actually wrong. The best example is from ancient Egypt. And so, if you go back to, 1852, they ended up doing what at best you can describe as an autopsy on an elderly Egyptian mummy.
Yes.
And they found that they had calcified aortic atherosclerosis. And so then in the early 1900s, they did a series of autopsies on these, Egyptian mummies. And again, they found in 3,000-year-old mummies, atherosclerotic lesions in the aorta and large arteries. So there was even one that in 1931 where they did the heart. So they were able to get the heart of Lady Tai, who lived in ancient Egypt between 1070 and 945 BCE. So she was 85 years old at the time. And what they found coronary artery disease in her, and they also found areas of myocardial fibrosis. So she had heart attacks before and healed. And so,
well, we can't blame the high processed food industry for that.
Well, that's the thing. The traditional food that they eat were beef, sheep, goats, wildfowl. They liked breads and they also liked cakes. But yeah, you're right. It's not processed food or anything. And this is now in an 85-year-old. So now they stopped doing this because it is destructive to the tissue. But we have modern techniques, and there's been the last decade or so, there was a research where they actually did imaging techniques on mummies. And they ended up imaging 52 mummies. Now, 44 of them had cardiovascular tissue or vascular tissue to evaluate. And they found that the average death of these people was about 39, plus or minus 12 years. Now, 20 of them had definite atherosclerosis, and 8 had probable. So about a bit over 60% of them had this disease process going on. Now, the 20 who had it with the atherosclerosis, they were aged about 45, plus or minus 9 years, and they had at least 2 or 3 vessels involved that had these lesions. And those without were about 34 to 35, plus or minus 12 years. And so the important thing to note here is that it's not representative sample of ancient Egypt.
Right.
So these are most likely nobility, people well-to-do because it was expensive to mummify a relative, nobility, priests or priestess, and oddly enough, the priests and priestess had better. They didn't show so much atherosclerosis, so their diet might have been a bit different. But the other interesting part about it is that it wasn't era relevant. So like over thousands of years, it showed the mummies from the different eras had the same kind of pathological findings. So it wasn't this era had a lot more than others. So look, so it's not a modern disease.
Right. So what is that? That's what that means, I suppose. It's not a modern disease.
It's not a, yeah. The difference is, it seems, just as a general statement, they would have died a lot earlier of a lot of other diseases that we won't die from today. So a lot of infections. If the average age is, 30, 35 to 40 of someone dying, then it hasn't had the time for the atherosclerosis to take hold. Mm-hmm. And so we do, because we are living as a general population a lot longer than they are. And so, there are factors that contribute to this disease, constitutional ones like, genetics, age, sex can't be changed. With regards to modifiable, we have things like hypertension, smoking, diabetes, and cholesterol. And so, look, there is a caveat in this. 20% of all cardiovascular events occur in the absence of overt risk factors. So there's still parts of the community will have a cardiovascular event without the risk factors that we know. But today, our focus is on modifiable factors for atherosclerosis, namely on cholesterol.
All right, let's get ready. We have a guest joining us in just a moment.
Wait! Stop!
You're back!
Yeah, we were wrong about the eggs.
How?
Well, it turns out there's two types of cholesterol. There's good cholesterol and bad cholesterol, and eggs actually have both. So you can eat eggs, but just don't eat the egg yolks. So stick with the egg whites.
Yes, thank you.
Godspeed.
Joining this pathological life now, we have Associate Professor Ken Sikaris. Now, Ken trained in science, then medicine, at Melbourne University before becoming a pathologist in 1992. He worked for several years at St Vincent's Hospital in Melbourne, including running a specialist lipid cholesterol laboratory performing research, as well as seeing hundreds of patients in the lipid cholesterol clinic. Since then, he's worked in private pathology, and currently in his job as chemical pathology director, he supervises testing on thousands of patients each day, including thousands of cholesterol tests. He's well known internationally in the fields of pathology, quality, and how we define the decision limits we use to interpret blood tests. He has several YouTubes on the low-carb Down Under site with a total of more than 500,000 views, and some may have seen him as Professor Blood in the Australian documentary That Sugar Film. With great pleasure, Ken, welcome to This Pathological Life.
Oh, thank you, Steve. It's a pleasure to be here.
It's a guilty pleasure for me because I'm the member of a low-carb community here in South Australia that has international members all over the place, and we are eagerly anticipating this question, this interview, even though we're bearing our GP listeners in mind. I want to start with this whole topic of cholesterol because it's a challenging topic for many of us, especially GPs, because the goalposts seem to be moving all the time. So could we start? Are there some fundamentals about cholesterol that are useful for GPs to know?
Yeah, I mean, I'm old enough to remember how cholesterol was taught in the past. And, cholesterol was like a dirty word in medicine. It was, the whole issue was related to cholesterol causes heart disease. And I think that fundamental modern understanding is that all cholesterol isn't just cholesterol. There's different types of cholesterol that we measure. And unless you understand those different types, in simple terms, the good and the bad cholesterol, unless you understand that breakdown, you do not understand what you're doing with cholesterol. And that's why there's such a debate in the community about, the usefulness of cholesterol and statins and so on. But there is, we have understood more and more over the last 20 and 30 years.
When a GP gets a pathology report, pretty much in cholesterol, you see you see total cholesterol, triglycerides, HDL, LDL, cholesterol slash HDL ratio, and then non-HDL cholesterol. So there's quite a bit of information there.
Yeah.
When they're looking at it, where should we put our money as to say this is the important part to take from this report? What do they need to focus on?
Yeah, look, it's sort of a sadness that the report has evolved in a way that its listing is inappropriate. The top line, which is the total cholesterol, is the least useful number. And the bottom line is literally the bottom line. The most useful numbers are those ratios, whether it's total cholesterol HDL ratio or the non-HDL ratio. So if there's a simple thing is look at the bottom line. Do not look at the top line. We had some working groups nationally to try to work out how to improve that report, to make it more useful and relevant. And one of the conclusions was that we shouldn't even report the top line, the total cholesterol. It's so useless. On its own, it's so useless. I think there's one laboratory in Australia that dared to remove that top line, the total cholesterol, and had to switch it on in a couple of days because of the community outcry. It's like, well, what's my cholesterol level? It's like, but the top line is really useless without, so going down the page, there's total cholesterol, and then there's a separate measure, which is triglycerides, which is really important. And then there's the breakdown of cholesterol, the HDL, the good cholesterol, and the LDL, the so-called bad cholesterol. Now, that gives you an idea of how the cholesterol is broken down, but the predictive ratios are using those values above in different combinations. So the total cholesterol divided by HDL, the total cholesterol HDL ratio, and that's what's used in the cardiovascular risk calculator in Australia. That's what every doctor uses to predict cardiovascular risk, the total cholesterol HDL ratio. Now, very strangely, total cholesterol divided by HDL, that's that ratio, and then there's total cholesterol minus HDL, and that's the non-HDL cholesterol, which is now reported on most reports in Australia. And that subtlety of total cholesterol divided by HDL or total cholesterol minus HDL, the bottom line is that those two figures together give us the greatest prediction. Right. Whether you do it as a ratio or as a subtraction, you have to take into account both those figures.
So the two lines, so cholesterol divided by HDL ratio and the non-HDL cholesterol are the two most important factors, and that's what you use to sort of manage patients? Yes.
Well, look, and I think there is a subtle difference between the two. Total cholesterol HDL ratio, as I said, is part of the cardiovascular prediction. It's the ratio that predicts risk. But it's not that great at monitoring treatment. And, well, in particular, the most common treatment monitored is statins. And so the statin community, if you like, have focused on the total cholesterol minus HDL, or the non-HDL cholesterol, as being the best number to monitor statin treatment. I don't particularly like them being used interchangeably, like saying that non-HDL is a good predictor of risk, or that the total cholesterol HDL ratio is what you should monitor in statin therapy. They're very subtly different, and so I think that you should focus on the total cholesterol HDL for risk. And if you are monitoring statin treatment, well, then the guidelines are based around non-HDL targets.
Okay. There is a growing sort of confusion also in one area that I wanted to ask you about, and this is fasting versus non-fasting cholesterol. There's, whether it used to be when I was studying that fasting is the mainstay. If it's fasting, this is what we know to be the baseline. Now I've seen literature that's talking about, well, that's actually not your day-to-day cholesterol. A non-fasting sample is actually more representative of what someone's going to be walking around the street with. And so it's a bit of confusion because GPs are going, well, which one do we use? And is there a recommendation? Does it matter?
There is a recommendation, and the recommendation is that it doesn't matter, but it matters slightly. As you say, Travis, most people don't actually fast for 10 or 12 hours on any day. So to have that as the reflection of their daily metabolism is, yep.
Ken, can I just interrupt?
Yeah.
Because
Yeah.
as part of the low-carb community I'm in, we sort of do
Yeah.
a slack form of keto.
Yeah.
Most days, Monday to Friday, I don't eat until after sort of 1 o'clock, 2 o'clock. So
Yeah.
does that mean I'm an outlier in this conversation? Because it might be closer to my normal cholesterol because I have such a large swathe of the week in which my body is operating in that context.
Well, that's true. We don't say that. Well, we do actually say with the fasting that there's an optimal period of fasting, and the ideal it's 10 to 12 hours fast. And generally, labs won't accept something as a fasting specimen if it's shorter than 8 hours, or if it's longer than 15 hours. And so, Steve, you've been fasting for longer than 15 hours. That means that your metabolism is different to somebody who'd only fasted for 10 or 12 hours. Your glucose levels are lower, the hormonal environment's lower. So it is true that level is not something we have an experience of or a feel for or cutoff values for. So but getting back to that issue about the fasting and non-fasting, again, after a meal, your cholesterol level falls. And there's lots of papers that show this. Cholesterol levels fall by 0.1 or 0.2 after a meal. And it's like, well, how could that be? You've just eaten cholesterol. Well, don't forget you've just exported a whole lot of cholesterol as bile to dissolve that meal. And not only that, but there's been a whole lot of fluid shifts in your body when you're absorbing the food that dilute everything in your blood. So typically after a meal, your cholesterol falls and everything falls, including your HDL, your good cholesterol falls. And so in terms of those ratios, both the total cholesterol and the HDL have fallen after a meal. But because they're much the same, the ratio doesn't change much. And that's what the push has been. It's like, well, if we're going to be focusing on those ratios, they don't change during a meal. So therefore, why do we need to fast? Now, I don't know, Steve, about those ratios after 15 or 24 or 36-hour fasts. I mean, I think they could change significantly. But yeah, as far as that meal. So the question is, well, then, why do we need to fast at all? Well, cholesterol doesn't change that much, especially the ratios after fasting, but triglycerides change. Triglycerides rise. The fat in the blood, the pure, the butter and saturated fats and everything, the fat that it absorbed into the blood does rise after a meal. Only by 0.2 or 0.3, but that's enough to, say, push a triglyceride, which should be under 1.5, to 1.7. And it's like, and then it's flagged as abnormal. So there's been a little bit of a debate around fasting and non-fasting triglycerides to say that, well, we should have different cutoffs for fasting and non-fasting because they are subtly different. And in my opinion, the fasting triglyceride level should be under 1.5 or 1.7. It's often referred to in metabolic syndrome. And the non-fasting triglyceride should be around below 2. So there should be a subtle distinction with triglycerides, but since most of the attention is on the ratios, total cholesterol, HDL ratios or non-HDL, it really, for most people, doesn't make any difference whether you're fasting or non-fasting.
And here was I naively thinking this was going to be a rather simple and straightforward interview this morning. Ken, routine checks, is there any advice from you on how regularly they should be conducted for people?
I think that if you've got a family history that, we don't fully understand what you should be doing or how intensely you should be treating, well, then you should be having periodic testing. But for most most of the community, the testing should be appropriate to that clinical need. So if you're putting on weight, or if your blood pressure's rising, or if your diabetes control is worse, then you need to test more frequently. There is a general guide that the older you are, you should have some routine tests every year or two. But for young, healthy people, I don't really think that they should be routinely tested every year or every 3 months. Or if everything's going well, then enjoy your life.
Can I ask then, which demographics aren't we targeting well? So you mentioned there's certain areas of people who have family history. Is there an area where you'd probably put most of your bang for a buck with someone that walks in and says, hey, this person would actually benefit from screening? Which demographic we're thinking about? Yeah,
look, there's, forgive the pun, the elephant in the room is obesity and overweight. It's really, over 70% of Australia is overweight or obese. And I do remember, and I'm not being critical of my GP colleagues, but I remember there was a paper in the MJA that reviewed primary care records and found that fewer than 30% of patients actually had a height and weight recorded in the record. And so it's something that's neglected. We focus on blood tests and blood pressure, and yet, what we see before us is that as an overweight or obese patient, that is the alarm in most Australians. So I think that is a broad issue. That's the starting point. Beyond that, I agree that if there's any sort of family history, strong family history, first-degree relatives, particularly under the age of 60 years, who've had heart disease, you really not only have to have a close look at the cholesterol, but measure other tests like lipoprotein a, which is an inherited form of, an inherited bad form of LDL cholesterol. And that's often neglected as well. People, just do the cholesterol. It doesn't seem to be high. It doesn't seem to be a familial hypercholesterolemia. Well, what else can we do? Well, you must do a lipoprotein a, because that could explain the entire family history.
Ken, as a patient, just a question on behalf of that patient-GP dynamic about the lack of weight being recorded. Yes. It does feel invasive and embarrassing to have a doctor get you on the scales, right? Well, at least for me.
Sure.
Do you think there's part of it there? And is if we were more conscious that there should be alarm bells ringing, maybe that should get us over that hump?
Look, I understand that. There's been, a lot of the low-carb community realise that, a patient's weight is not entirely their fault. It's like the fault of this toxic environment we've created with refined foods and really addictive foods. And so there should be a greater understanding that, those people who are overweight are not just lazy people who eat too much. It's like they're the victims of how we've created Western society. It's like it's not just Australia, of course. It's even worse in the US and in the UK. So, that it is embarrassing, but really, unless we start facing that issue, and really over the last 5 years, I would say, soft drinks and everything, it really just, people understand the harm in those sugary drinks. Those drinks that have no cholesterol, but a ton of sugar. It's like, well, we understand that that's the problem, and but it's not an easy problem. But I do think that, really, if a clinician wants to make the point that there's lifestyle modification required, they probably should put the patient on the scale.
Now, I was going to ask, with regards to treatment, going back to looking at the cholesterol itself, is there a particular value for non-HDL cholesterol that GPs are aiming for with statin treatment? Is there a magic figure at the moment? I know it always changes, and I know the recommendations always change, but is there a target at the moment for when this patient is on statin to be aiming for?
There's sort of a soft target, if you like, of around 3, and then tighter targets for patients who are still at higher risk or need more aggressive therapy, and that's generally under 2.5 or less. There's usually 2 targets, depending on whether it's primary prevention or secondary prevention and so on. But I'm actually uncomfortable about talking non-HDL because when we talk about the residual risk with statin therapy, so statins do not prevent all heart disease. They reduce heart disease, but they do not prevent it. And when we look at that residual risk and the attitude of, well, if there's risk where you need an even lower non-HDL cholesterol, it's ignoring something, which is the contribution of triglycerides to that risk. And most of the papers that look at residual risk understand that it's those elements of insulin resistance, of high triglycerides, blood pressure, and so on, which are really causing that residual risk. You can't treat triglycerides with statins. You can't treat blood pressure with statins. You can't treat all of the, fatty liver with statins. So that residual risk has to be addressed with lowering triglycerides. And that's where, we don't have great therapies. Combining statins with fibrates, is a way of lowering that. And certainly we're not as scared of combining those medications nowadays. But as the low-carb community understands, there is a magical way of lowering triglycerides, which is paradoxically eating fat.
It is challenging areas there.
It was the biggest attractor for me, I must confess.
But it's an understandable thing if you just switch it around. How do you teach your body to burn fat? It's by eating fat. It's like by making that your fuel. How do you teach your body to store fat? It's like by giving it an alternative fuel so that it doesn't burn at fat stores, like giving it carbs. So it's really even though it seems paradoxical, it's surprisingly simple concept to manage.
Now, I was going to ask about guidelines because there's so many guidelines out there from heart foundations, from general practitioners, from pathology. Is there one that you would recommend to probably keep an eye on that's probably the most relevant to GPs trying to actually just keep abreast of all this information?
Well, the National Heart Foundation guidelines, even though they do, they're pushing non-HDL and so on, it is the reflection of all of our experts and people that, like me, have been in the area for 20 or 30 years. To be totally honest, not all those experts understand the nuances of fasting or non-fasting or triglycerides or total cholesterol HDL versus non-HDL cholesterol. But they know what works. And so they generally are on the right track, even though, in my opinion, they don't quite understand fully the modern perspective on how those lipoproteins are metabolized. So I wouldn't, there's no alternative at the moment. That's the point, is that there's no specialist group which has formed a radically new view of interpreting lipids and managing cardiovascular risk. And so, like always, a GP uses the guidelines from those authorities, the guidelines to guide their thoughts, but not dictate their thoughts. So that, there's a subtle difference in pathology when we talk about guidelines and requirements. A requirement is something you must do, whereas a guideline is sort of some tram tracks to just keep you on the general track. But you should always, as a trained professional, use your own judgment and your own experience to make that final decision. So that's why I'm sort of saying that it's a good starting point, the National Heart Foundation guidelines, but you really should take into account all those guidelines are really only updated every 5 or 10 years. So it's very easy for them to fall out of, current practice.
Mm. Now, I was just going to ask, there's a few other tests that I'm going to throw at you just to get your thoughts on. So when we actually do VLDLs, when is that important, or is it important at all?
Yep. So VLDL is the particle made by the liver that's full of triglycerides. So it's the fat-containing particle. We don't measure VLDL cholesterol. What we measure is triglyceride and assume that the triglyceride has a direct relationship with the amount of VLDL. So, and a laboratory could, and they do, just divide the triglyceride level by 2.2 and give you the assumption of what the VLDL cholesterol is. That's a part of the Friedewald calculation the laboratories use. And it's actually how we calculate LDL, because we don't measure LDL. We just take the total cholesterol, take away the HDL, take away the VLDL cholesterol, which is the triglyceride divided by 2.2, and what's left is LDL. So laboratories, 99% of the time do not measure LDL. They calculate it with this assumption of what the VLDL cholesterol is. Now, labs can measure LDL directly. So there are assays available for LDL direct assays, and that gets rid of all the calculations and assumptions. It's useful when the triglycerides are really high, because the calculation of LDL when the triglycerides are high is unreliable. And so we can use the direct LDL assay when triglycerides are really high.
Mm-hmm. Now, you did mention before, when is it relevant, or when is it important to do lipoprotein A testing?
Yeah, well, lipoprotein little a is LDL that's got a tail on it, the apolipoprotein A protein tail, and it's atherogenic. We're not entirely sure why it's atherogenic, whether it forms thrombus more, or it becomes smaller and denser faster. But that particle, not only the number of tails you might have on your LDL, but also the length of those tails vary from genetically. There's nothing to do with the diet. And so in some families with high levels of LDL or very long tails, it usually goes hand in hand. You have high levels and long tails. They have a family history which is often, quite bad. Like fathers that have died in their 40s, non-smokers, normal cholesterol. That's what I'm saying. When you've got a family history that is not explainable, then chances are Lp(a) will explain that family history. So that's the particular situation when the familial cardiovascular risk seems unjustified in terms of every other measure we've got. Mm-hmm. And so not only should that person have Lp(a) done, but if it's found to be elevated, normal levels at, let's say, under 300, some of these patients have levels of 1,000 or 2,000, then that they should be encouraged to have the family tested.
And the last test I want to throw at you, and I'm trying to work out if it's relevant, it's always a bit of a challenge, is chylomicron testing. Where is that relevant?
That's a good question. So chylomicrons are the triglyceride particle made by the gut, by the intestine, as it's absorbing triglycerides. And so it's actually the fasting of 8 to 10 hours, which lowers triglyceride level, is because we clear all the chylomicrons. So after 8 or 10 hours, we expect there to be no chylomicrons left from the last meal. But it varies from patient to patient whether they clear those chylomicrons in 4 hours or 8 hours or 10 hours. And that's related to insulin resistance. And so some patients don't clear them even after 10 or 12 hours fasting. And they've got either a severe form of insulin resistance, or they may have a genetic problem in clearing chylomicrons. So generally, but we only generally think about chylomicrons when the triglycerides are clearly elevated, like not above 1.5 or 2, but above 3 or 4, let's say. Then we're starting to wonder, well, maybe there's more than just VLDL cholesterol, the liver triglyceride particle in the blood. Then maybe there's still lots of intestinal triglyceride particle, which is chylomicrons. And there, the usual way we check for that is by doing lipoprotein electrophoresis, which can look at all the different particles, including the presence of chylomicrons. The labs can actually see chylomicrons without any fancy tests, because if you sit blood that's got a high chylomicron level, it'll have a milky top layer, like just a very fine millimeter or so at the top of the serum, which is the very buoyant floating chylomicron particles. So sometimes labs, when they report the serum was lipemic, it's a suggestion that there are chylomicrons present in this patient's blood. So either they didn't fast properly, or they've got a problem in clearing chylomicrons, whether they be insulin resistance or genetic.
Wow. The last thing we'd like to ask you is to see if you could stand on tippy toes and peep over the horizon. Is there anything coming down the pipeline that might give us hope as far as cholesterol management is concerned?
Oh, there's a test that I've been dying to get into the country, and it's called phospholipase A2, or lipoprotein associated phospholipase A2. It's a big word. It's got nothing to do with Lp(a), nothing to do with LDL. What it is a product of the foam cells. So the cholesterol, LDL, small dense LDL particles are taken up into the plaque, and the macrophages in the blood vessel wall take them up and just engorge themselves on the LDL particle, and they become foam cells. Now, in the past, we used to use high sensitivity CRP as a measure of the inflammations being caused in the body from atheroma. But this lipoprotein associated phospholipase A2 is a reflection of that foam cell activity, if you like. It has been, I know the Mayo Clinic's been using it for years, and they've been using it in studies to try to work out who to give the very expensive PCSK9 inhibitors. It's a really expensive way of lowering cholesterol. But it's a way of selecting the patients who are at greatest risk. It's a measure of plaque activity. So we've got the calcium scores, which tell you whether the plaque has been calcified, whether there's plaque present. But it would be wonderful if we had a measure of whether that plaque is active, or whether it's dormant, if you like. It's not progressive anymore. And so that test, the reason why it's been a bit of a problem getting into the country is because the company that developed the test, sold it off to the highest bidder, and that company was really enraptured by its potential, and it seems to me they priced themselves out of the market, and the company collapsed. So anyway, the test is being released again. We hope to have it soon, and I think that it'd be really, to be able to look into the plaque would be such a wonderful thing.
Well, Ken, you've got Dr. Travis Brown now salivating to get back to the lab. Meanwhile, I'm salivating to go and have a nice juicy steak for lunch.
Good on you.
So, Associate Professor Ken Sikaris, a.k.a. Professor Blood, thanks for joining us on This Pathological Life.
No, it's been great. Thanks.
Yeah, okay, so it turns out that the amount of cholesterol in a food doesn't actually affect how much cholesterol ends up in your blood. The eggs are probably fine. In fact, we sort of don't even know what cholesterol is. But the steak! You can't eat the steak!
Why not?
Turns out that red meat increases your chance of heart attack. You have to cut out red meat. So no steak!
Thank you.
Godspeed.
This Pathological Life is produced by ClinPath Pathology in South Australia. Episode notes, references and learning objectives, when applicable, can be found at thispathological.life.com.au. And you can contact the hosts on Twitter via @Dr. Travis Brown or @Steve Davis. Thanks again for listening, and just a reminder, if you haven't done it yet, have a quick search in your podcast app for our second series, This Medical Life. Dr. Travis Brown has rolled up some extra guests, some extra topics, and we continue the story there, and we'd love to have you along.
Are you a podcaster? Maybe you've got that big idea and you're looking for a network to join. The multi-award-winning Ozcast Network can get your content to eyes and ears all over the world. Join now for the first month free, and you could be featuring this sound at the beginning of your podcast.
Ozcast.
Simply head to ozcastnetwork.com for details.